Hi, I'm Dr. Danny Felty, a family medicine physician and Legacy Care's Chief Medical Officer.
And I'm Julie Miller, a nurse practitioner and Legacy Care's Chief Compliance Officer. Thank you for listening to the Legacy Lamp podcast.
With us today, we have Dr. Sarah Szanton. She is a professor at Johns Hopkins University in the School of Nursing. Dr. Szanton also is an endowed professor for health equity and social justice and is the director of the Center for Innovative Care and Aging. As a former health policy advocate, she aims her research and publications toward changing policy for older adults and their families. Dr. Szanton graduated with a Bachelor of Arts degrees, magna cum laude, from Harvard College. She then earned an undergraduate degree in nursing from Johns Hopkins University School of Nursing, where she also earned her Master's of Science in Nursing. Dr. Szanton next earned her Doctor of Philosophy from Johns Hopkins University as well. We'd like to welcome you, and it's an honor to have you with us today.
Thank you.
Dr. Szanton, welcome. In your bio, I read that you are the recipient of the prestigious Heinz Foundation Award in the Human Condition category, and that was based on you leading the development of the Community Aging in Place Advancing Better Living for Elders program, also known as CAPABLE. This program provides a low-income older adults with handyman services alongside with in-home nursing visits and occupational therapy. The goals, as I understand it, are to improve health and mobility, restore dignity and independence, and decrease healthcare costs. Early in your career, when you were making house calls, I understand you observed challenges that your patients face when caring for themselves and moving around in their homes, and how that impacted their overall mental and physical health, as much as or more than their medical needs, and how that was often a determining factor in their ability to age in place. Can you first give us an overview about CAPABLE and how you were able to successfully address some of the unmet healthcare needs you observed through your work?
Sure, and thank you so much. When I was a nurse practitioner providing house calls, it was exactly as you just said, that I would come thinking about their medications or their diagnoses, but to walk into someone's house and have them basically stuck in a chair because there were holes around them in the floor and their closet perhaps was broken and where they couldn't open it, or they had linoleum curving up broken in their kitchen floor and they were using a soap dish as a thing to lean on to get into the bath. I could see that my focus on what they needed medically was really limited compared to what mattered to them to be able to function. And my eyes were really open to how much we tend to think what we're doing as providers is the most important thing. But being able to do the most basic things like be able to get dressed or bathe oneself or get food and prepare it are underneath all of those. They're foundational. They're the real primary care. And so in geriatrics, there's a concept of person-environment fit, that disability comes from a misfit, that someone maybe has less capability, but that their environment matters as well. So we developed CAPABLE, adapted it from the ABLE program, which already existed, which is occupational therapy and some home modification. We added nursing visits and home repair to make a program that was tailored to older adults to help by creating an environment that was supportive of them and meanwhile addressing their pain and depression and other things relating to them. So, and we started in one place in Baltimore. It's now in 33 places in 17 states.
Oh, that's amazing.
That's great. Yeah, and it's very apparent that the underpinning of CAPABLE had a focus on addressing environmental challenges. Similarly, our new transitional care management program also is addressing issues that often drive patients back to the hospital after discharge. For example, we have an advanced care practitioner and physician manage the care of patients who are high risk for poor health and healing outcomes along certain areas, and those include medical management, home safety, help with appointments for follow-up, home care, and skilled care. In your experience, do the areas we're addressing with transitional care management mirror some of the areas you saw your homebound patients struggle with too? And we could run through some of those categories, maybe with some specifics, starting with medical management and home safety.
Sure. Yeah, I mean, I think in one of the things that the nurse does in Capable is go through all their medications. And I know you know from the work that you do that a lot of times there's no one else besides who's in the home who knows everything they're taking, right? Some of it is over the counter, some of it's from specialists. And
Right.
so even just a simple medication calendar that reconciles everything and that has perhaps pictures on it or common sense language about how to take it and what it's for can be, revolutionary for people.
That's great. Yeah, I think specific to medication management, just the availability of the medication can be important also. Similarly to food scarcity, but then also be amiss that the great nursing 5 R's is important to look at their capability of understanding that, as you said, the basics.
Right.
Anything specific to home safety? You mentioned some of the things you observed. Anything that you've noticed a trend there?
Absolutely. And I think that, for decades, home health and other programs have worked to provide some home safety for people after a surgery, perhaps, a bath chair, but that there's underlying needs when people have aged in a home. They may have been there 30, 40, 50 years. And it may be harder and harder for them to get someone in to fix it. I think right now we have the highest percentage of older adults who've lived in their place for more than 20 years that we've ever had.
Wow.
And I know I have a hard time finding, a handy worker or someone. And so being able to have someone who can go through with an occupational therapist based on functional needs and look at maybe they need a second banister on their main stairs. Maybe the railing is shaky coming in. Even really simple things like, strips on the bottom of their bathtub so it's less slippery,
Right.
or lowering their cabinets because we all shrink as we age. We've gotten crock pots for people, for example, who have dentures and they can't really chew. And so to us, home safety is part of it, but also everyday items that make life easier, like the crock pot or a pull chain on the bottom of a ceiling fan so they're not climbing up onto their kitchen table.
Right. Yeah, definitely fall risk is something we all try to mitigate. And I guess with the next point regarding follow-up, help with appointments. When you've worked through your program, have you also noticed that at least based on the literature, we know that about 40% of patients in these transition time zones don't get follow-up on tests or labs that may have occurred. But also there's the issue with follow-up to their appointments. How have you seen that come into play in your work?
Yeah, so one thing that's distinctive about Capable is that we only focus on what the person wants to focus on. Even with the medications, we say we offer this to everyone, and if you would like it, you can have it. And probably 97% of people do. And similar with safety, we don't focus on you should get rid of this rug or your small dog is a trip hazard. We focus on what they're concerned about and we try to frame it as their mobility and their independence rather than that they might injure themselves. And similarly with appointments, we figure that people feel nagged sometimes by systems or by their grown children, and that our role in Capable is just to focus on exactly what they prioritize. So if that's part of what they want to focus on, I'll give you an example with appointments. We've had a number of people who are missing appointments because the mail comes through a mail slot and drops to their floor and they can't bend down to reach it. And so we've done a really simple thing of just a little netting under the mail slot so they can grab their stop appointments. So if someone prioritizes making the appointments, or in this case, getting their mail, absolutely work on it. But we never do anything unless through our assessments, the older adult prioritizes it.
Sure. And specific to, obviously working with other entities, for example, home health or whatnot, or some of these follow-up visits, do you ever find that transportation is an issue that you have to address? Like if they're interested in that topic, as you just mentioned, do you find yourself working on the transportation issue?
Absolutely. And sometimes we're able to sign them up for what in Maryland is called mobility, basically transportation for people with disabilities. And, I think transportation is a huge lack across the country for any urban, rural, suburban, almost any setting. Transportation is an issue and really important. And it's great that I think you all offer that as well.
Right. Yeah, we're definitely kind of directing traffic in that way. I might hand the next question off to Julie.
Um, okay. I'm passing the buck here. So I was wondering if possible that you could expand on Capable's OT solutions to improve mobility and reduce the disability and commonality of how Legacy Care's TCM aims to promote safe healing and reduce infection, causing patients to return to hospital and experience best possible outcomes for recovery and healthy living after discharge. Your program is going to be key in helping to foster this, trying to keep people in their home environment, because certainly they heal better.
Right.
After our focus is post hospitalization. Yours is pretty much just long term. Like how can we keep people safely in their homes?
Right.
But so what other, I know you mentioned, having a handyman come in and with the OT and kind of walking through, but what other things do you really look at to try and help to keep people safely in their home environment?
Right. So with Capable, the older adult identifies 3 goals with a nurse and 3 goals with the OT for what they want to be able to do functionally. And so the way we look at it is that what the work with the OT is foundational, but sort of necessary but not sufficient. In other words, let's say with the OT, they want to work on being able to get in and out of the bath, being able to walk down the driveway to get to their mailbox, and being able to prepare food for their grandchild that they used to really like to do.
Right.
If they're in a lot of pain, or if they have a really low mood or depressed, or if they're on so many medications that they're kind of nodding off or really disoriented, they won't be able to practice those goals. So we look at the nurse and the OT and the handy worker all being stick or their strengths. And so with the OT in particular, so for the example, in being able to walk down to the mailbox, or being able to shave standing up, for example, instead of in a wheelchair. Let's take the shave one. So the nurse might work on strength and balance exercises. The OT would see where in terms of their height and what they can move, they would need to be able to grab onto, and what their shaving equipment is. So with the OT, it's a combination of the equipment and the clinical judgment about what they can do physically and what they're hoping to be able to do. And in that case, the nurse might have worked on maybe knee pain and the strength and balance. But underlying all of this is the human dignity. And I think you all, underlie that as well, that being able to prepare a meal for someone you love, or get your own meal, or shave standing up. Those are things that we all take for granted. We all got dressed today and went where we were going and put food in our mouths. But back to the medication that we discussed about, if you can't take care of the daily items, then it's hard to be engaged in the larger project of life, of the larger being able to take care of the higher order things.
Mm-hmm.
Mm-hmm. So I know that obviously one of the big focus, I think, across the board is, the cost of healthcare. And I know just from my own research, looking even just a cost comparison of, an assisted living resident versus a long-term care resident. I think the last estimate, now these are 2018 numbers, if I'm not mistaken, it was $90,000 a year to stay in long-term care. And it was roughly $45,000 a year to stay in assisted living. Certainly Capable is doing a lot to keep people in their homes, but what are you doing? Because obviously the things that we do, all of these, having an OT and having a nurse come in, those things are all related to a cost. So how are you looking to drive down the cost in healthcare? What is it that you guys do?
Yeah, so great question. And what we found is that these really non-medical approaches that we've had are saving real medical dollars. And both CMS has found, and we have found in our research, that Capable saves about 7 to 10 times what it costs. So it costs about $3,000 a person, and it saves somewhere between $22,000 and $30,000
Wow.
over the next 2 years.
That's amazing.
And we think the bulk of that is in the first year. And that's really inspiring to us because I think we thought that it might break even. But because people who have decreased function are much more likely to be hospitalized than the average older adult, or much more likely to be in a nursing home, either temporarily or permanently, a small investment can make a big change in terms of cost savings. And as you know, we're at a historic moment right now to realign what patients care about, like function, with what costs society and health systems, and in terms of accountable care organizations, Medicaid waivers, the way Medicare Advantage is going. And it's really a ripe time to focus on people's daily function to be able to save the hospitalization and nursing home costs.
Yeah, that actually is a big piece of why we really wanted to get into the whole transitional care management. The unfortunate side of, frequent readmissions and that, that whole return to hospital piece that CMS looks at. They look at those 6 key diagnoses that they've identified as return to hospital risk. And, each hospital, as you know, is kind of looked at, and they're kind of graded as to what their percentage of return to hospital is for those 6 diagnoses. And what, it used to be, at least when I was a nurse, I was told, oh yeah, well, they don't get paid if the patient comes back to the hospital within that 30 days. And that's actually a misnomer. That's actually not correct. But what does happen is every year they look at their percentage of return to hospital, and they set whatever bar they feel is appropriate. And if you are above that bar, if your return to hospital rate is too high, then the hospital actually gets kind of dinged, is what I'd call it. So they're fined basically a percentage of all of their Medicare patients that go back to that are in the hospital. It's not just those 6 diagnoses, and so that equates to millions of dollars in return to hospital that the hospital actually loses. And so what we're really focusing on is trying to get people safely home and make that transition, optimize that transition to minimize that risk of return to hospital with, like you said, medication reconciliation, making sure that they understand what those medications are for, because I think a big piece of that medication is compliance. And if they know that a drug doesn't make them feel good, they're going to be less likely to take it. And so trying to, go through each of those medicines and, oh, that medicine makes me feel nauseated. And okay, so what can we do to mitigate those to make sure that you're taking care of yourself, but we're also not making you feel worse with the medications that we're giving you. And so really that's the piece that we're really focused on, is trying to get them to safely transition home. And, if they need a caregiver, is there a family member that can step up? And I know a lot of times with COVID right now, people really have. They've brought their loved ones home from the long-term care facility to safely care for them at home, and it's been successful. And I think that's really where your company, your program, Capable, really comes in to really help foster that and give them success at home.
Right.
Yeah, I really like you mentioned previously, kind of asking the patient and engaging them on those three goals. That's very identifiable. I remember being in the office for a number of years that you would assume they were there for sinusitis, but then sometimes you would ask the patient, well, what can I do to help you? And it was, help me get that bathtub fixed. So, well, along that same lines, I think you mentioned it before, we're at a pivotal point in history, and I know that the pandemic has exposed some of these opportunities, hopefully. Can you speak to how Capable has been able to use patient data and analytics? We're starting to see that in our transitional care model that we can use predictive analytics in a new and innovative way to maybe create a more patient-centered care model, that we can look at proven analytics and ways to find out maybe certain patients with similar diagnoses aren't really the same, and being able to tailor make strategies to their care. Can you speak to that with Capable?
Well, I'm a little old-fashioned on tailoring and believe in just asking the person what, and we haven't done so. I'm a researcher. I'm a professor And we developed Capable. The 33 sites around the country are run by individual places, some primary care practices, some Meals on Wheels, some Habitat for Humanities, and Medicare Advantage plans. So I know that they are working on trying to figure out how to best target and use the data they have from Capable to kind of close that loop in terms of figuring out the next steps. But that's not something that we've been doing at Johns Hopkins.
So, I know that, so really, like Dr. Felty said, we really have discovered that we've got some innovative ways to assess analytics and assess a patient's high risk for return to hospital and that sort of a thing. And so hopefully with that, we're going to start from discharge from the hospital and see it through to the home and really try to help identify those, similar to you, those risk areas of what issues do they need to address in their home to keep them safely there. So hopefully, we can maybe we can partner at some point, because this sounds like an amazing you have an amazing program. This is definitely something that is needed in the community. I think that, like Dr. Felty said, the Band-Aid has been ripped off, and I think we're realizing that there is a significant need that needs to be met with our geriatric population, and whether it's it's necessary for them to be in an assisted living, or if it's safe for them to go home. I think that your program has definitely identified a need, and it's being met, and that's an amazing service.
Thank you.
Yeah, and I think what we're finding in looking at predictive analytics and some of the disease management is that the hospital systems and some of our partner organizations like wound care agencies and even home health agencies are running more predictive analytics than they did years ago. And so what we're finding is that in some areas they've been able to, in effect, triage some of these cases. And we've been able to integrate some of that because we know it's going to continue. AI and machine learning are going to continue to play an important role. So we're excited to try to work with some of that and be able to take best care of the patient.
Sure. Yeah.
As you look at Capable's work, do you think this is going to, and I know you can be retrospective, but maybe prospective as well. How's it going to impact the next generation of healthcare providers?
Yeah, that's a great question. So we have training that we've developed that is online and on demand for new capable clinicians, new OTs and new RNs. And what they tell us is that after they've done Capable, it makes them approach all their other patients differently. That we tend to, in schools, often in hospitals and other places, often train our providers of any type as though the provider knows everything and the patient knows nothing.
Right.
And that the patient is kind of an empty vessel that the provider fills with their knowledge. And we might ask them some questions, but then we will fill them with our answers. And Capable really flips that on the head and makes it that the older adult is the expert on their life, and that the clinician's job is to listen and use their clinical experience and their pattern recognition and what they've seen from kind of their own data analytics in terms of their mind and what they've seen before, to help the older adult prioritize and brainstorm. I'll give you an example. We had a participant who spent all day on a commode chair next to her bed, and she hadn't been downstairs in 2 years when we got there. And as we worked with her, and part of it was realizing she was being completely over-medicated because of some mistakes in the medication, non-reconciliation, she got really excited about a goal she had, which was to get downstairs. She hadn't been down in 2 years. And as they started to brainstorm about this, the OT didn't say you should do this and this and this. The OT had used our training to be able to help the older adult brainstorm that she wanted to put plastic deck chairs along the hallway that led to the stairs, and she would practice herself just getting up and walking a few feet and sitting down. She was so weak. And if we had come in and said, you should really do some chair stands to strengthen yourself to get downstairs, that wouldn't have flown nearly as well as her coming up with that idea. And now this woman leaves her house even, comes up and down and is not isolated in her room. But I think that Capable is innovative, but it's also in the stream of innovation that many programs are, which is treating people as people rather than patients, treating them as whole people with interests and values and passions and experiences. And that in terms of the future healthcare workforce, I hope that that will expand beyond people who are trained and capable.
Sure. No, that's great. One last question as we're kind of winding up a bit. How do you feel the pandemic has impacted Capable, your program, and what solutions have you had to think about for those who might now be homebound or had a fairly significant change during the pandemic?
Yeah, so I think the pandemic has both created problems and laid bare problems that were already there. And I think in terms of healthcare systems realizing, oh my goodness, it's much better if someone's at home than in an institution of a lot of rooms down a hall. I think we've always known that, but now it's become even more clear. And there's also going to be a lot of people who are newly disabled, from COVID. And but on the plus side, there's a lot more ability to deal with some things by telehealth and other technologies that a lot of older people have realized that they can do visits, by an iPad or other things. So I think it's a really mixed bag, and on top of it being a tragedy, of course, and that there's a lot of room for opportunity for changing. Every plague has created a lot of change in the societies that experience them. And I think COVID will be that way as well.
Sure. Any questions from you, Julie?
I don't. I think we've covered everything. Thank you very much for your time. And this has been a true pleasure.
It's been a pleasure chatting, and we appreciate the positive, kind of life-changing impact you've had on the behalf of older adults. And we'd also like to thank our listeners of the Legacy Lamp podcast. Our podcast serves as a forum for healthcare professionals and consumers. It's a place where the brightest minds in medicine and healthcare discuss industry topics that impact lives.
Visit lgslegacycare.com to learn more about our organization and find archived copies of our show.